comment below. Started? Okay. So in the comment, just let me know if I'm audible and visible to you guys. So today we are going to start with the fetal circulation and ECG. Right. I'm just waiting if you can just say hello to me, because I'm not able to either read the chat because the video is playing right now. I'll just check whether the sound is okay or not. Okay, from my side it's okay. Just give me a thumbs up or yes or something like that. Hi guys. Hi Nagesh. Bache, it is complete, but they are not for the first prof. They are just for the NEET exam or INICT. Okay, Aladita. Prince, hi. Am I audible? Let's start. Thank you, Ashutosh. Hi, MS. Let's start with the fetal circulation and then we are going to... Thank you, Barun. Then we are going to move on to the ECG. Now understand, don't expect me to cover the ECG in 1 hour or like everything starting from the physiology and then the pathology and medicine. That I'm going to cover definitely, but not now. Okay, we are just going to focus on the physiology because that is what my subject is, right? So hi, good evening, Ayush, Prince. Let's start with the class. Right, so fetal circulation, what is the basic difference? What you can say me about the lungs of the baby, or we can say lungs of the fetus and lungs of the adult human being. Just let me know one simple difference, is very basic difference that you should know first. Good evening, Varun. Chalo, tell me the basic difference. There are two major differences. If you know that, we are good to move forward, right? First is in the lungs and second is in the liver. First is in the lungs and second is in the liver. दोनों के L is there, so दोनों के लगे होते हैं, right? So hi Dr. Soni. What is AFMS? Barun, hi. So tell me what are the basic differences but in the lungs and liver of the fetus and in the adult. Can you think of anything? So just simply remember these are starting with the L and L. So in the fetal life it is going to be LL. That means unke L lag gaye hote hain, right? So what do you mean by that? First thing, lungs are functionally inactive. They are there, but they are useless in the fetus per se, right? So they are functionally inactive, completely inactive. Okay, so we can write they are completely inactive, right? Underdeveloped. Varun, yes, you're right, they are underdeveloped, and there are two differences. Underdeveloped means something is working, right? Like underdeveloped countries or underdeveloped roads of India, right? But they do their functions to, make us travel, though we suffer while traveling, but they make us go from one point of station to another destination, right? But definitely inactive means suppose there is one accident or something like that and we are not able to travel on that road, so that means the inactiveness. Okay, so that is the basic difference. What about the liver? Liver is active, but remember it is partially function. It is partially functional, not fully functional, it is partially functional. That means you can write it as it is partially inactive. So the liver is going to be partially inactive and the lungs are completely inactive. Good evening, Siddheshwar. Right, there are many students right now, so hope the topic that I chose is going to be interesting, right? If you give me the answers and you give me or start giving me the different comments, right? All right, let's move on. What is the design of fetal circulation? I'm going to show you a small GIF, right? Then you can understand it better. So see over here, what is the difference that you can see? Can you tell me what are the differences that you can see? Especially if I'm going to start with this. What is this? Over here. This is placenta that is shown over here. So placenta is not present in the adult life, obviously. So placenta is going to be there in the fetal life. And remember, the oxygenated blood from the mother's blood or from the placenta, it is going to go via the umbilical vein. We are going to write everything, don't worry about that. Just look over here what I'm telling you, okay? And what are these? These are the umbilical arteries, okay? Vein carries oxygenated blood and the umbilical artery carries deoxygenated blood. There are only two exceptions where the artery carries the deoxygenated blood and vein carry oxygenated blood. One we learnt over here, that is umbilical vein. What is the another example? Can you tell me another exception where the vein carries oxygenated blood and the artery carries deoxygenated blood? Tell me, guys. Please make it interactive. That way it is going to be more interesting, right? I'll make sure that it is going to be more interesting, but you have to interact. Otherwise, it feels very stupid, to be honest, to talk in the camera and getting no comments whatsoever, okay? So I don't want that experience. That is very, very bad. It feels like I'm teaching to camera, and which is non-living thing, okay? So first difference is that, and you are going to tell me the another exception. Perfect. Rishabh, wonderful, excellent. So in the pulmonary circulation, Nagesh, wonderful. So in the pulmonary vein also, there is oxygenated blood, and pulmonary artery, the deoxy blood is going to be there. Prince David, very good, bache, very good. Then you can see over here that in the liver there is some circulation. So it is going through the liver, but understand there are two circulation. Can you see that from the portal vein also it is coming, and from the umbilical vein it is also coming. So that means this blue one which is shown, I'm writing it over here, that is portal vein. So remember, portal vein and the umbilical vein both are draining into the different structure. Usually that is not there in the adult human being, okay? So what is that structure called as? That is called as both veins are coming together and they're forming a duct, right? So both veins, that is portal vein, umbilical vein, it is going to form a duct which is called as the ductus venosus. Their entrance where they combine and drain the blood and forward the blood towards the heart, that is known as, since two veins are there, so that's why we are going to call it as ductus venosus. Okay, just try to understand. We are going to write each and everything. If you want to note it down, just note it down right there. Okay, now this is the ductus venosus. I cannot write that because as soon as I'm pointing towards that, it is pressing the pause button. I do have image, I'll show you there. Okay, then after this ductus venosus, where they are combined together, you can see that from the inferior vena cava they are going into the right atrium. Okay, and from the right atrium you can see that they are, rather than coming into the right ventricle, it is going into the another atrium, that is towards the left atrium. Okay, so from the right atrium it is going towards the left atrium. That means there is opening between this septum. There are two septums, if you know that. So I'm just going back to the slide so that it will be easier for me to write. Now understand that suppose this is our heart, simple diagram. Okay, so if I make two, this is a septum, right? So these are two atria, right atrium, right ventricle, left atrium and left ventricle. Now understand there are two septum, different septum. This is known as atrial septum. Septa means which causes separation, so that is septum. Okay, so this is atrial septum and this is ventricular septum. Septum means the one which causes the separation. Okay, it should be complete in the adult human being, but understand in the fetus the atria, they are connected to each other, and the structure which is connecting them, so there is a pore which is available or the door which is available whenever the blood is going to come through the vena cava over here, right? What is going to happen once the blood come through the vena cava, that is inferior vena cava, definitely from the superior vena cava also it is going to come, but for now we are talking about the inferior vena cava because we are going from the placenta towards the umbilical vein, combining with the portal vein, then ductus venosus, after the ductus venosus inferior vena cava, from the inferior vena cava right atrium, from the right atrium at least 80 to 90% of the blood will go towards the left atrium. Now understand why it is happening, so we'll see that in a minute, but just understand that the left atrium, the opening from where it is the blood is going into the left atrium, this part is known as foramen ovale. This part over here is known as foramen ovale. Very good Ritesh, Varun, yes, which is fossa ovalis after the birth. So now we are going to call it as foramen ovale. Now there is another possibility that we are going to have in the ventricle also septum, right? But that is not normal, so I am going to rub that up. It is might be possibility that we are going to discuss whenever we are going to discuss about the pathologies. Okay, now I got to know that the blood went into the left atrium. Now what will happen to that blood? That blood obviously will come into the left ventricle and it is going to go to the aorta, right? So let's go back to the GIF again and you'll understand it. So you can see over here what is happening, that from the, I'll change the color over here, from here to here the blood is moving. So you can see from the right atrium the blood is moving towards the left atrium, then it is coming into the left ventricle, and from the left ventricle it is going towards the aorta. Now we can see the aorta is descending, the abdominal aorta is forming two different arteries, and what are those? We know that they are going to form the umbilical arteries. Now understand, almost we can say 55% of the blood will go back into the placenta for oxygenation, right? That means only 45% blood is there for the whole entire body tissue of the fetus. So that means only whatever blood is coming from the placenta, only 45% blood will be circulating in the fetal tissues, and the remaining 55% is going to just go in the heart and come back into the placenta. Okay, the saturation is around 80% when it comes in the umbilical vein, and definitely as the tissue grabs it, it is going to decrease. The partial pressure of oxygen is going to decrease. Now one more thing happening over here, I told you some of the blood will come, and definitely from at least from the aorta also the blood is going to 45% blood we have to circulate, right? So blood is going to circulate from the arch of aorta and different branches which are there, and they are going to go to the different tissues. Now if I talk about the upper limb, what is going to happen? The head of the baby, if you would have seen, the head and the upper limb is much more larger as compared to the lower limb. As we grow, they are going to be in an equal proportion. But since the brain development is very important, we have to provide more blood there. So if the blood is going there, and after the exchange of the gases, it will come back also. From where it is going to come back? We always know that the blood is going to come through the superior vena cava, whatever upper portion that we are talking about, or the portion which is there in the head region of the fetus also. So you can see over here, this is the superior vena cava, right? And from the superior vena cava, it is draining into the right atrium. Inferior vena cava, the blood is coming from the ductus venosus, right? And from the superior vena cava, that means from head region, whatever deoxygenated blood is there, it is going to come from the superior vena cava into the right atrium. Now once it comes into right atrium, it is going to go in the right ventricle. Understand, right ventricle is going to have this blood, and it will try to send it in the pulmonary artery and towards the lung. But we just now saw that the lungs are inactive and alveoli over there are collapsed. So you can say that the lungs are inactive means alveoli are collapsed. Plus, whenever we do have hypoxia in the lung, you must have seen, I told you that there is only one exception. Yesterday also I asked you to tell me the mechanism of it. I gave you the hint. No, Shubham, you are on time. We are just discussing the basics itself. Okay. Ritesh, beats. Now remember, 4 to 5 weeks, the beats will be started. The heartbeat will be started. Okay, and that's why there are different ultrasound, different types of ultrasound. What we do is, there are probes, right? So through the vagina of the mother, we can go in the uterus level, right, and see the feel the heartbeat or movement of the heart. We can see. Trans-abdomen means on the abdomen, rather than going on the uterus, we can just go from the abdomen. In that, it is going to be later, that means 10 days later. But basically they say that the CVS development starts from the 4th week, and around 5th to 6th week we are going to see the heartbeats. Okay, Ritesh? Now that depends from which investigation you are looking at it. Okay, let's move on to the next thing. That I told you that the hypoxia is going to cause vasoconstriction. So there is a very high pulmonary resistance present in the lung. So what is going to happen? There is a lot of high resistance. Now remember, see over here, there is opening. At this point, can you see there is opening? Some blood is coming over here. There are 2 arteries which are joining. This is the aorta, and I told you this is the pulmonary artery. So pulmonary artery, and this is aorta. Now both of them are arterial sites, right? So that is going to, I hope this is visible to you guys. Okay, so that got cut. I'll write it again. So this is the aorta, right, and pulmonary artery. Now understand, these 2 are arteries which are joining together and forming the duct. Now if something forming duct which is on the arterial side, we are going to call it as ductus arteriosus. 2 veins, that is portal vein, umbilical vein, ductus venosus. Okay, the foramen between the atria, foramen ovale. And over here we are going to talk about when they together combine, and that opening is known as ductus arteriosus. Now understand, when I'm going to talk about ductus arteriosus, over here I told you that there is a high resistance. So what is going to happen? Most of the blood is going to go into the aorta via ductus arteriosus. And since there is very high pulmonary resistance, what is going to happen towards the lung? Only few amount of blood or very less amount of blood is going to go towards the lung. So that is the 3 major things you have to remember. First, you have to remember about the ductus venosus over here, then the foramen ovale, and then the ductus arteriosus. 3 things you have to remember. If you understood these 3 things, you are almost sorted about the fetal circulation, that you can get at least, let's say fetal circulation comes for 4 or 6 marks, definitely you are going to get half of it. Okay, so 3 things which are different. This is the diagram. I am quoting it, that it is from the Guyton itself directly, international edition. So see over here, the diagram is clearly telling you what is happening. So this is the umbilical vein which we already discussed. umbilical vein over here, which is carrying the oxygenated blood, and that's why it is shown in the red color, right? And then it is going, maximally it is going towards the ductus, after the ductus venosus, going towards the inferior vena cava, right? And then from here the portal vein is draining the blood into the ductus venosus. Now understand, the liver is partially functional, and that's why their sinusoids are also obstructed, or you can say they are constricted also. Okay, and that's why there is again high resistance, so only small amount of blood goes in the sinuses of the liver, and most of the blood goes towards the, so high resistance in the liver. Again lungs में तो high resistance है ही, and even in the liver sinusoids. So only a small amount of blood will go in these two areas, and definitely most of the blood will try to go back towards the aorta, and from there back towards the placenta via umbilical arteries. Okay, so yes, most of the blood gets to the aorta. I told you that 55% we have to send back. So 55% plus maximum tissue, whatever, I'm going to tell you the percentage also because I have diagram for it, right? So you're absolutely right, Varun, that it is going to go to the aorta. Okay, so that is going to be there, and you can see that this is the inferior vena cava, this is superior vena cava, and you can see over here the ductus arteriosus, and here that they have shown, this is the what thing, I'll just highlight them rather than circling it so it will be visible also. So see over here that this is going to be the ductus foramen ovale, this is ductus arteriosus, ductus venosus. Okay, let's move on as you guys ask me the question. So if I divide the right atrium and left atrium separately, or right side of the heart and left side of the heart, this is how it is going to look like. So suppose this is RA and RV, LA and LV. Now what is going to happen, you can see from the ductus venosus it is going to come towards the RA and RV, then it is going to move from the, most of the blood moves from the ductus venosus towards the aorta. Very less amount of blood is going to go towards the lung because there is very high resistance. Why? There are two things which we will discuss. The major important thing is the hypoxia. First thing we already discussed, that the lungs are inactive, and second, because the alveoli they are collapsed, what is going to happen? Definitely there will be hypoxia induced vasoconstriction. What was the hint I gave you yesterday? What was it? Oxygen sensitive dash channels. Tell me what was the channel name. Homework किया है किसी ने आज? नहीं किया तो लाइव झंड है ना, मेरी नहीं उस चैनल की, राइट? ओके, so and then it is going to come towards the aorta. Now quickly see the output that you have asked me, and then I'm going to make you write everything, that how it moves, from where it is going to move, right? So that you can make that same chart in the exam also. So what we saw is that this is the right side and left side. So you can see over here that the blood is, first of all, from the placenta it is going to move over here, right, in the right atrium, and some of the blood is going to come into the right ventricle, but it is very minimal, so that's why they haven't showed the arrow. And from here, where the blood is going to go, from here the blood is going to go towards the left atrium and left side, and from the aorta it is going to go towards the minimal blood will go towards the lung, and maximum it is going to go towards the placenta back again. Now see over here, from the left ventricle only some amount of blood will go towards the lung, and maximum amount of blood will come towards the placenta. Now see, I told you that whatever blood comes in the, this is again given in the Guyton itself, international edition, the latest edition, I guess it is 13 or 14, right? So right atrium says, see over here, almost 55% is going to come towards the placenta, only 45%, remaining 45% is going to get distributed in the all tissues, right? So 55% back to placenta for oxygenation, and only 45% is going to go towards the fetal tissues, all tissues. Now, if the lungs are inactive, who is acting as the oxygen sensor and exchanger to the fetal tissue, or I can say who is acting as the lung of the fetus? Tell me. Thank you, Teju. So who is acting as the fetal lung? That is going to be your question. Fetal lung. Fetus is a parasite. You know, we all have been through that phases. Parasite of our mothers, right? So that's why the Mother's Day is very, very, very important, right? उनकी चप्पल भी खा लेते हैं. So Mother's Day. So what I'm telling is the parasite. Parasite, they don't. What is the difference between parasite and any functional thing? Parasite, they drain the energy. That means they take up the nutrition, they take up the oxygen, they take up the energy, but in return they don't give anything much, right? So it is known as parasite. So who are the parasite? The things, or the politicians, or some people who do not do what thing benefits of us, and they just work for their own things. Okay, so don't worry about next, Ritesh. Whatsoever exam is there, we are going to prepare for it. Okay, so don't waste your energy thinking about all these things. Yesterday only I told you, convert your worry time into study time. If it is difficult, it is going to be difficult for all of you. Okay, if it is easy, it is going to be easy for all of you. Whatever it is, we are going to be prepared for it. Okay, so that is our aim. It is not our aim to think about what is going to happen, because even if we think, that is not going to change. And please remember, in the next 10 NEET PG, thankfully they do have percentile. That means suppose 100 people gave the exam, and out of it is going to see that 50%, first 50% are going to be passed. Suppose the first rank itself got, let's say, 48% in the next exam. So let's say first 50 percentile of student, 50 ranker, 50% rankers, if they get the marks till, let's say, 33% also, so that is counted as the passing percentage. Okay, so that is the percentile, not the percentage, right? So thankfully we do have system like that. So don't worry, it is going to be the same result whether you know the concept or not. What type of blood supply? The blood supply is going to be mixed. Okay, mixed venous blood is going to come. We'll come on that. PaO2, I have separate slide for that, and that's why I didn't discuss over here. Okay, so this is the ductus arteriosus and forequarter, that is the head region. From here also the blood is going to come from the right atrium to right ventricle, and from there some of it will go towards the ductus arteriosus, and some of it will try to go towards the lung, but there is again a very, very high resistance. So what is going to happen? It is also going to go towards the lung, not lungs, the hindquarters, that is through the aorta. Okay, so maximum blood is going to go through the aorta. So let's quickly write the no need to delete the comment, it's okay. Whatever you are going to write, I am going to answer, because they are genuine question. Don't be afraid to ask the question. Okay, they should be academic. All right, so let's move on. So we'll make a flow chart, right? So umbilical, let's start with the placenta rather than umbilical veins. Placenta, from the placenta it is going to go in the umbilical vein, which is carrying oxygenated blood. How much will be the oxygenation? Over here it is going to be 80%. Okay, so it is going to be 80% saturation. And from the umbilical vein, where the blood is going to go? From the umbilical vein via the ductus venosus. So I am going to write like this. So over here from the umbilical vein and also from the portal vein. Very less amount of blood flow towards the, what you can do is you can make this arrow thicker and there is going to be a thinner arrow. So liver, that means it is small amount of blood go to liver sinusoids, but they are compressed, so not much amount of blood. Now why it is going to the liver sinusoid? It can, all the blood can go towards the next part, that is the ductus venosus. Remember, we have to make the tissue to survive and not go in the necrosis or apoptosis. So that's why for survival, whatever adequate amount is there, we have to provide it to it. Okay, so I'm writing the next thing, that is it is going to go from the ductus venosus towards the let's write like this. From the ductus venosus, it is going to go towards the right atrium, right, via the inferior vena cava. And as soon as it is going to go from the inferior vena cava, from the right atrium, it is going to go through the foramen ovale, foramen ovale. It is going to go towards the left atrium. From left atrium, it is going to move towards the left ventricle, and from there it is going to go towards the aorta, isn't it? And definitely from the inferior vena cava we have talked, and I'm just writing from the head region. It is, I'll just complete this aorta first. Aorta is going to ultimately give the blood to the tissue, and after giving the blood to the tissue maximum, again from the umbilical artery, the blood is going to go back to the placenta. You can write over here 55%, right? So 55% go back to the placenta, and 45%, you can write it over here also, that the 55% goes to the umbilical artery and the placenta. Why? Because it is going back, and 45% goes to all tissues. Okay, and tissues, I mean the upper limb also and lower limb also. From upper limb, understand, I'll write in the black color over here. So upper limb, especially the head region and upper limb, the blood will come from the superior vena cava, and this superior vena cava blood will go in the right atrium. From there it will go to the right ventricle. From right ventricle it will go to the pulmonary artery, right? It became very congested. Upper limb से it is going to go to the superior vena cava. From there right atrium, right ventricle. From right ventricle the blood will go in the pulmonary artery. From the pulmonary artery, maximum of the blood goes to the aorta, but some amount of blood definitely is going to go towards the lung. Why? Again, we have to make the tissue survive, so lung also requires nutrients supply and some oxygen supply also. Okay, and this connection over here from the artery towards the aorta, it is known as, I'll just make a star mark over here, and this is known as ductus arteriosus. Okay, you have to know this chart very well so that it will help you out in the exam also. So first we learn about ductus venosus, foramen ovale and ductus arteriosus. These three things you have to remember. Okay, and I asked you who is going to act as the lung for the fetus. Already he is or she is the parasite, and the placenta is the savior. That means the placenta is going to act as the lung for the fetal tissue, right? So this is the thing. And oxygen saturation in the placenta and umbilical vein it is going to be at the level of placenta and umbilical vein. It is almost 80%, right? What is the normal oxygenation? Can you tell me what is the normal PaO2? That means arterial side oxygenated blood has how much percentage of oxygen partial pressure? Lower limbs के लिए बच्चे, it is going to get provided via the arteries, right? And via the veins, it is going to drain back into the aorta, and from there it is going to come in the umbilical vein again. Okay? So that is going to happen, Varun. Next, cardiac output of the fetus will come on that. Don't worry, we have everything covered, right? I will tell you what is the cardiac output in the fetus. Okay, let's move on step by step, you know. So PaO2, when it circulates, it is going to get circulated, right? And the tissue is going to get almost 40 to 60% PaO2 blood. Okay, so that means it is the mixed venous blood that the fetus is going to get. The fetus is going to get, the tissues are going to get, fetal tissues, they are going to get the mixed venous blood, that means which is having around 40 to 60% of the partial pressure of oxygen. What is the normal pressure, partial pressure of oxygen in the adult life? Still buffer हो रहा है. Is it fine now? There is some technical issue that is going on. Yeah, I know. थोड़ा सा patience रखो. Yes, we are back. Now understand that in the normal adult system, I hope it is fine now. In the normal adult system, it is going to be around 95 to 100. 95 to 100 mmHg. Black screen. Rishabh, Varun, now is it fine? Because it is fine in my laptop over here. Chalo, let's start. And I take these as I'm in the studio, I'm not at my home. So take them as the challenge for your patients, okay? Yes, above 95, you're absolutely correct, Rishabh. So 95 to 100 mmHg is going to be the PaO2 in the normal adult. But see over here, 40 to 60% is going to be in the fetal tissue. Now, if it would have been also 95, then what would have been happening? First thing is that there is no gradient. If there is no gradient, the oxygen won't flow because this is the gas. So this gradient is very, very important. Understand, we're talking about the adult. So in the adult, it is 95 to 80 and the mother is the adult human being, right? And there should be at least 20 ka gradient which should be present, that is 15 to 20, that should be there. So we can write there is a delta P that should be there, and if the delta P is there, because the oxygen is the gas and it goes via the diffusion, right? It goes via the diffusion, and for that the main thing that we want is the, rather than delta P, we can write it as delta C, that is the concentration, right? Partial pressure, you can write it as P for partial pressure or concentration for C, okay? So oxygen concentration in the blood, okay? So there should be the partial pressure or the concentration gradient that should be present. The gradient is must. The gradient should be must, okay? So that is the case, and that's why we require this. Now there are some special features about this oxygen saturation also, that understand that there are fetal hemoglobin, that is something different, because from the mother's blood, the fetus has to drag the oxygen also. It should attract, right? So there should be some magnet available in the fetus. And what is that magnet? Can you tell me? Yes, please tell me, who is the magnet which is attracting the oxygen, and what is so special in the fetal lung? First thing I told you that there is a gradient which is helpful, but there is another thing which is going to be helpful, which is different in the adult also. Okay, coming to the high PVR, I told you why there is high PVR. PVR is not the cinema theater that I'm talking about over here. It is the pulmonary vascular resistance. Pulmonary vascular resistance that I'm talking over here, right? So high PVR, that is the very high resistance which is applied. Why? Because the fetal lungs, they are collapsed, and collapsed lungs means lung, they are made up of mainly alveoli. So collapsed alveoli I can write over here. So there is a relative hypoxia kind of a condition which is present. So I'm writing relative hypoxia. Why hypoxia I'm writing? If I just write hypoxia, that means fetal hypoxia. And in the fetal hypoxia, there is a chance that the fetal death will occur, but we are taking it in the relationship, or we are comparing it in the relatively towards the adult wala alveoli, right? So that's why we are taking a relationship between, or comparing between, the adult and the fetal lung, not what should be normal for the fetus. Okay, so I'm writing there is a relative hypoxia condition in the fetus, and that's why the vasoconstriction can be seen. Nobody gave me the answer till now, that it was the potassium channel that I asked you. Why? Because there are oxygen sensitive potassium channels which are present in the pulmonary vessels, which are going to respond in the way of constriction whenever there is hypoxia. Understand? Anywhere else in the body other than the lungs, whenever there is a hypoxia, there is going to be vasodilatation and not the vasoconstriction. So this is the only exception. Mark it, because this can be asked as MCQ also. Exception. Why? Because thanks to the oxygen sensitive potassium channel. Okay, oxygen sensitive potassium channel. Oxygen sensitive potassium channel. All right, so relative hypoxia, that means as compared to the adult, and because of that vasoconstriction, that is the main reason resistance is going to be very high. Now understand, because the resistance is high, what is going to happen? That when the resistance is higher, the blood is going to be moving towards the, most of the blood from the foramen ovale, it is going to go towards the left atrium rather than it is coming from the right ventricle into the lungs. Okay, and due to the aorta is opened, wide open, right, and that's why the systemic resistance is low. Okay, so rather than going the blood flowing into the pulmonary artery, it is going to flow, but later on. Okay, not from the inferior vena cava, it is going to go in the pulmonary artery. Inferior vena cava blood is going to go in the left atrium. So there is right atrium se seedha blood is going to go in the left atrium rather than going into the right ventricle and towards the next thing, and which is the thing which is going to help us, or opening, that is foramen ovale. Okay, so collapsed lung, and that is why it is going to go towards that. Okay, so this is the thing, most of the blood is going to go from the right atrium towards the left atria. And the second thing, I'll write it over here itself, because we have already made the chart that from the, even if from the superior vena cava, when the blood comes into the right atrium and goes into the right ventricle, from the right ventricle also it will go in the pulmonary artery, but from the pulmonary artery most of the blood will go towards the aorta, right, and the thing which helps us, that is ductus arteriosus. ductus arteriosus. Okay, that is going to go again towards the aorta, and the whole tissues 45%, 55% towards the placenta. And please understand, if the lungs are collapsed, the placenta is acting as the fetal lung. So make a point over here, the placenta, it acts as a the lung of the fetus. Why? Because the oxygenation is done by the placenta itself, right? It's the parasite which is sucking the blood from the placenta, the fetus, right? And once upon a time we were also in that condition, so we should thank our mother. Next, effect of hypoxia. What is the effect of hypoxia per se? We know first effect is going to be vasoconstriction, where in the fetus, and the fetal hemoglobin. I asked you, what is that magical thing which attracts like a magnet? It is going to attract the oxygen from the mother's blood, and that is going to be the fetal hemoglobin, that is HbF. What is so different in the HbF? The adult hemoglobin, it is called as HbA. Understand, the fetal hemoglobin has different globin chains. Hemoglobin, that means heme molecule will be there, and globin chains are going to be there. How many globin chains? In total 4 globin chains are going to be there. And how many types? Only 2 types. That means each type will be having its pair. So I'm going to make over here 1, 2, 3, 4. Now what are the chains that are present in the adult, and what are the chains that are present in the fetal hemoglobin? Alpha are going to be common in both, but understand, in the fetal circulation it is going to be the gamma which is going to be present, and instead of beta, right? And there is very important point over here, that the gamma globin chain in the fetal hemoglobin, it has more efficiency or affinity towards oxygen. What do you mean by affinity? Affinity means attraction, right? As you are attracted towards studying, right, and not wasting time. I'm very thankful, such a acha bachas, right? So you are having affinity towards studying, right? So same over here, the fetal hemoglobin is going to have the affinity towards the oxygen. And remember, it is much more than the beta chain. Okay, so I'm writing over here gamma chain having and oxygen affinity, that means attract the oxygen towards the beta chain. Can I ask you reason why? Because understand, on the gamma chain the 2,3-BPG cannot bind. If the 2,3-DPG binds onto the gamma chain, there will be difficulty, because there are limited seats for the oxygen, right? On one chain, one molecule of oxygen will bind, that means 2 atoms of oxygens are going to bind. But if those seats are taken up by 2,3-BPG, so 2,3-BPG, right, or 2,3-DPG also, di and bi, you can call anything. Remember that it is produced by the Lubering-Rappaport pathway, and there are limited seats. It's like a musical chair, right? So there are limited seats. If one is binding to that side, the another cannot bind. So that's why the affinity towards the beta chain is less. Why? Because understand, I have deliberately made you write B over here, because 2,3-BPG only has affinity towards beta chain and not towards the gamma chain. It cannot bind to the gamma chain. That's why more and more seats are available for the oxygen to bind, and that's why the oxygen comes and bind onto the gamma chain, and that's why it is having more attraction or more affinity towards it, right? You dress well, so there are chances that you can attract better partners, right? So that is there. As we know, BMR is high in pregnancy, so different should be. Okay, I'll do that. Okay, not now, we are into a flow, we'll do that. Okay, we'll do that at the end. Let's move on. That effect of hypoxia. There are serious regulatory mechanisms also. What is going to happen to them? What are the serious regulatory mechanisms? Especially if I ask you what are the main ones, the baroreceptor ones and chemoreceptor short-term regulatory mechanism. Remember, if there is hypoxia is going to be there, how the CVS is going to be activated or inhibited? The hypoxia is everywhere, relative hypoxia, but rather than having the central control, they are controlled by the local factors. So instead of central control, it has the local factor. It get affected by local factors. So please remember, the hypoxia is there, but it is not going to change the CVS regulatory mechanism, or it is not going to activate the CVS regulatory mechanism very much. Why? Because in the fetal life, they are activated by the local factors and not by the centers which are present in the medulla, right? And what about the baroreceptor and chemoreceptor reflex? Understand, they won't be activated in the fetus. Okay, somebody asked me that also, that the baroreceptor and chemoreceptor reflexes, they are inactive through the fetal life. Most of the fetal life, they get activated throughout most of the fetal life. IUL means intrauterine life. Intra means inside, uterine means in the uterus, and life means life. Okay, intrauterine life. Uterine means in the uterus of the mother. So the fetal life is also known as intrauterine life because depending on the site, this name is given. The activation of that, they are activated at around 30th week of intrauterine life. 30th week of intrauterine life. From now onwards, the intrauterine life, I am going to mention it as IUL. That is going to be mean by IUL, that is nothing but the fetal life. Okay, intrauterine life. So around 30th week, that means in the third trimester only it is going to get activated, not in the first trimester, not even in the second trimester, only and only in the third trimester it is going to get activated. Coming to the changes occurring at the birth. Now we have discussed that main thing over here to remember. Just if you want to remember, what you will remember? Just, I'm writing like here, just point that you have to remember, that please remember that the alveoli, they are collapsed. Okay, or write down summary like that, better word. So very, very high pulmonary vascular resistance and relatively low systemic vascular resistance. Systemic vascular resistance. Okay, so low systemic vascular resistance, and most of the blood is going to go via the systemic circulation towards the placenta again for the oxygenation. The second thing that we learn is that there is a relative hypoxia condition. Relative hypoxia condition, isn't it? Relative hypoxia condition. Now remember, this is going to be very, very helpful, and three things which are there, which are not there in the adult life. What are those three things? First thing, that is going to be the ductus venosus, then there is the foramen ovale, and then there is ductus arteriosus. Okay, the DV, FO and DA, that is going to be there, right? Let's move on the basis of that. So can you tell me what should have happened now? The first change that is going to happen as soon as we cut the placenta, we can write it over here that the placenta is acting as the lung. Placenta is acting as lung for the baby, lungs for the fetus. Okay, lung for the fetus. Okay, lung for the fetus, right? So let's move on and see what are the changes. So I have to change this everything. Okay, I don't know how it got written over here, that is there is no HE. All right, fine. So understand these points I have to change. There must be change in the adult life. First thing, as soon as the baby is born, there is no connection of placenta. So what is going to happen? I'll just give you overview on this 4 points. That first of all, as the baby is born, what we are going to do? We are going to cut the or clamp the umbilical vein and umbilical artery. That means there is no connection from the placenta, so there is no lungs. If there is no lungs, that means oxygenated blood is not coming. And if the oxygenated blood is not coming, what is going to happen? The baby is also going to feel hypoxia. More and more, now this is not relative hypoxia. The baby itself is going to go in the hypoxic condition. That means there is no oxygen supply towards the baby, right? And if there is no supply towards the oxygen, now what is going to happen? That his respiratory centers which are present in the medulla, they are going to get activated. As soon as they are going to get activated, what is going to happen? Definitely, they are going to send the signals towards the lungs and towards the alveoli. And for the first time, the baby start to cry within few seconds. And I told you that this is going to be very, very important. In the general physiology itself, we have discussed that there is something known as Head's paradoxical reflex. Okay, Head's paradoxical reflex, that means as soon as in the first cry of the baby start to cry, he is going to inspire through the mouth also and from the nose also. So the alveoli start to stretch, right? And unless and until they come to the normal position, they will stretch. That means the inflation of the alveoli will stimulate further inflation, that is positive feedback mechanism. Right, in the H2 clamp mnemonic, we learn about H. 1H is going to be the Head's paradoxical reflex. All right, so that is going to take place over here, and for the first time, the alveoli start to work. As soon as the alveoli are going to get the oxygen, there is no relative hypoxia. So what is going to happen? These collapsed alveoli, they are going to open up, right? And that means for the first time, the pulmonary vascular resistance will start to decrease. Now understand, if the pulmonary resistance start to decrease, what is going to happen? Now the blood will start coming from the pulmonary artery in the lungs also. For that, we should increase the systemic resistance also, systemic vascular resistance. How that is going to happen? We are not just clamping the umbilical vein, we are clamping the umbilical artery also. If we clamp the umbilical artery, for the blood which is already present in the systemic vascular area, that is not able to go forward. So what is going to happen to the left atrial reserve? It is going to increase, and because of that, already accumulated blood is going to be there, and because of that, what is going to happen? Definitely, there is going to be increase in the systemic vascular resistance. So we reverse the condition over here, right? The detail we'll learn one by one. For now, we have covered 3 points, that the placenta is going to cut down its connection, then the alveoli, they're going to open up, and the systemic vascular resistance is going to increase, pulmonary vascular resistance is going to decrease. The relative hypoxia condition, that means in relation to adults, but over here there is asphyxia condition which is going to develop. That means there is almost absence of oxygen supply in the baby. Now we cannot call it fetus. Fetus means in the uterus. Now the delivery has been taken place, and now we are talking about the baby. So what is going to happen in the baby? Let's see that. As soon as we clamp umbilical vessels, so first thing that is going to happen, that we are going to clamp the umbilical, I'm just writing UMB, that is umbilical vein. That means what is going to happen if you clamp the umbilical vein, there is no supply of the oxygen from the placenta. No more supply. You can write no more supply of oxygen from placenta. As well as we are going to clamp umbilical artery. So it is going to put back pressure from systemic vessels. Now why there is back pressures? Remember, because of accumulation of the blood. Because of accumulation of the blood. Now there is something known as stripping of umbilical cord also, that we'll learn later. For now, just remember this is going to take place. Okay, so that is going to take place, and because of this umbilical vein we have cut, so the pulmonary vascular resistance is going to decrease, and that's why the blood will start to. Why? Because for the first time the alveoli is going to open up. Okay, umbilical vein we have cut down, no oxygen supply from the placenta, so there is a condition which is developed which is known as asphyxia. Asphyxia, that means almost no supply of the oxygen for few seconds. Okay, so no supply or absence of breathing. Okay, so asphyxia means absence of breathing, almost no supply of the oxygen. I don't know why these lines are coming. Okay, almost no supply of the oxygen, that means asphyxia. It's a severe condition than the hypoxia. Hypoxia means reduced levels of partial pressure of oxygen, and if they go way more below, that means severe hypoxia is called as asphyxia. Can remember that, right? Very low partial pressure of oxygen. Okay, so almost no supply, so partial pressure of oxygen is going to be decreasing or falling of the partial pressure of oxygen on the arterial side also, right? So pulmonary vascular resistance is going to reduce. Okay, that will take place. Okay, so first thing, when the pulmonary resistance is going to reduce, what is going to happen? One more thing, that whenever the two things are responsible for that, what are the causes of decreased PVR? First thing, because of asphyxia, it will activate the respiratory centers, and whenever there is activation of respiratory centers, it is going to stimulate the lungs or open up the alveoli, or stretching will start of the alveolar, or we can write inflation will start. Okay, so note down, first thing there that we talked about is the heads. Head was the name of the scientist. Paradoxical. Can you tell me what do you mean by paradox? Something known as paradox is, whenever we called as paradox, that means something should happen, right? Like you should reply to me, but after some time you don't. The class is still going on, but there are no replies. That means what should happen, the things are happening in contrast to it. Okay, yesterday was I was asking in the end the question, but there was no reply, because this is only the subscriber mode, so only the subscriber I guess can chat over here. I don't know, it is showing to me the subscriber only mode for the subscribers of the Cerebellum channel, I guess, right? So head's paradoxical reflex. So this is the reflex. What should happen in the adult, the exact opposite phenomena is happening in the, or contrast phenomena is happening in the fetus. That exact opposite or contrast phenomena is known as paradox. There are many paradox that you are going to learn in the physiology. The first paradox you are learning right now, that is the head's paradoxical reflex. The inflation of the alveoli, it says that the inflation of alveoli should In the adults, it is going to, that means inflation means it is going to activate the stretch receptors, and the stretch receptors via vagus, it goes and stimulate the medullary centers, and what they are going to do, they are going to inhibit the further inflation. That means they are going to inhibit the further thank you, Varun. So they are going to inhibit the further inflation so that our alveoli should not burst, right? But over here we have to inflate those alveoli, and that's why first cry of the baby is very, very important. He is crying, but everyone out there is happy, right? So that is what happens in the real life also, right? When we cry, everybody is happy at that time. Okay, so when they see the medicos in the stress, all over the world they are happy because we are in the stress. So inflation of the alveoli will stimulate further inflation. That is only going to happen in the first few breaths. So this is valid for first few breaths. As soon as the alveoli is sufficiently stretched now, it is inflated now, this Head's paradoxical reflex will never occur ever again in the life. Okay, so this is also known as the first cry of the baby. Okay, this is cutting down. This is known as first cry of the baby. This is known as first cry of the baby. And this is very, very important. You must have seen in the 3 Idiots also, he's padding on him. That happens in the real gynae ward also, that we want the baby to cry. The reason over here is the Head's paradoxical reflex, because most of the air goes from the oral area first, right? And that activates the Head's paradoxical reflex. Very, very important. And for the first time, the alveoli are going to inflate properly, and there is no more hypoxia. And if inflation causes that inflation, because of the inflation of the alveoli, will increase the oxygenation in the alveoli. That means there is no hypoxia now. And what is going to happen? There is one more thing. First thing is oxygenation. That is going to cause opening of the pulmonary vessels. So I'm writing over here opening or dilation of pulmonary vessel. Opening or dilation of pulmonary vessel. There is one more thing which is very, 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 very important. That is nothing but the PGE2, that also helps in the dilatation of pulmonary vessel. And this effect is known as, especially this oxygenation causes dilation, this is known as pulmonary vessel relaxing effect or relaxing effect. This is known as relaxing effect. What is relaxing effect? It causes the dilatation of pulmonary vessel, and that's why the pulmonary vascular resistance is going to decrease, right? As the lumen is increased, the intraluminal resistance is nothing but the pulmonary vascular resistance, and that is why the vessels are relaxed now, and the pulmonary vessel is going to have less resistance. Over here the R means resistance, so resistance is going to decrease. What is going to happen to the total peripheral resistance and blood pressure? When I say total peripheral resistance, I'm not going to count the pulmonary vessel in that, because that is the central vein. Okay, the lungs and the heart vessels, they are took as the central vein, right? Now when I'm going to talk about the total peripheral resistance, that means I'm talking about the body's resistance. Okay, the vessels which are present in the systemic circulation, what is going to happen to them? Remember, I told you that we are clamping the umbilical artery also, and that's why the blood cannot go forward, so it will start accumulating backwards, and once it start accumulating, it will put the back pressure. Not only that, the hydrostatic pressure will increase, and because of that, what is going to happen is there will be increase in the total peripheral resistance. As the total peripheral resistance is going to increase, obviously the BP is also going to increase. Okay, so both of them because of back pressure. So you can write the reason over here in the short, that clamping of the aorta, clamping of umbilical artery, that is going to cause the back pressure, right? Because there is an accumulation of blood. There is no outlet which the blood can get. Okay, so not only the total peripheral resistance and BP is going to increase, but there are going to be changes in the liver circulation also because of this. So we are going side by side simultaneously. The story is going on. I hope you are liking the story, right? So the back pressure is going to be there, and that's why what is going to happen, the total peripheral resistance and the BP is going to increase. TPR is total peripheral resistance and the blood pressure. Blood pressure is going to increase. The BP will increase, isn't it? The BP is going to rise. Now what is going to happen to the LA reserve? What is LA? It's not Las Vegas, है ना? Sir promised us that they will bring something from LA to us, but they himself, he haven't gone there, right? One of my senior. Now LA pressure, that means I was talking about the left atrial reserve. Understand, everything was going from the aorta towards the left atrium, aorta and towards the body, and the aorta is going from the left atrium to left ventricle. That means the back pressure is there. That means the blood is started accumulating in the all systemic vessels, as well as the abdominal aorta, thoracic aorta, in the left ventricle, and finally the LA, that is left atrium. So obviously left atrial reserves are going to increase. Reserve means the accumulation of blood over here, right? Why? Because, and with that there are some changes. Pulmonary resistance, that is going to fall. Closure of umbilical vein is going to occur, and that is responsible for, yes please, that is responsible for lack of oxygen again and the resistance. Occlusion of umbilical artery, we have discussed that, that is the back pressure that is going to put. Now because of this occlusion, two things are going to happen. First thing, there is a back pressure, and we have closed the inlet, that is nothing but the umbilical artery, umbilical vein. Now understand, the blood is not coming from the umbilical vein, but there is a back pressure, lot of back pressure is there. Now what is going to happen, because of the closure of the artery and there is no much of the blood which is present in the umbilical vein, actually there is a constriction of the ductus venosus that is going to take place. And understand, because the muscles are going to contract over there. Why? Because again PGE2 is going to be not there, because that comes in, that is the vasodilator which is responsible over there, which is not going to be there, and that won't be able to dilate the muscles of the ductus venosus. So via cutting the or occluding the umbilical artery, what is going to happen? There will be constriction or contraction, let's say contraction of ductus venosus. If the ductus venosus is contracted and still the back pressure is very, very high, the blood is forced into the liver sinusoids, and that's how the liver vessels are going to open up and the portal blood finally start to go in the liver sinusoids. Okay, so first thing I'm writing over here, that there is going to be the portal blood. Why? Because there is a lot of back pressure, the blood has to go somewhere, it has to move somewhere, right? There is going to be the another pathway which is going to be there, that is nothing but the portal system. Portal system. So blood is forced into the liver sinusoid. So back pressure is there, a lot of hydrostatic pressure rather than hydrostatic pressure. Increase in the hydrostatic pressure of the portal system. I hope you can see that. Hydrostatic pressure, so that's why blood is forced in liver sinusoids. And after few days to years, days to months, this contraction of the ductus venosus finally is going to close forever also. Okay. Yes, Ritesh, you answered about the Head's paradoxical reflex. Yes, you are right. right? So this is going to take place, that the umbilical vein. So finally we have done with the closure of ductus venosus, because there is no much of the blood which is coming from the umbilical vein, right? Two reasons: no supply of blood, umbilical venous blood, and increase in a HP, that is hydrostatic pressure in the portal system, and there is a contraction of, or the lumen is going to get narrowed. So narrowing of ductus venosus, which will finally result in the opening of this liver sinusoid. Why? Because the blood is forced into the liver sinusoids. Let's move on to the next thing, that is foramen ovale. Let's see that what is going to happen to the foramen ovale. Understand, as soon as I said that there is no blood from the inferior vena cava, now what is going to happen? Definitely there is increase in the reserve of the LA, right? We have just now saw that. I'll write over here. If there is no space, I'll move on forward. So because of this 3 dot means because of increase in the LA reserve, what is going to happen, bacho? LA reserve. Because of increase in the LA reserve, what is going to happen? That the pressure in the left atrium is going to increase. LAP means left atrial pressure. Now left atrial pressure is going to be more than right atrial pressure. Why? There is less of the right atrial pressure because there is no blood which is coming, na? So obviously if the blood is not coming, there is no much of the hydrostatic pressure which will remain there. And what is going to happen? Foramen ovale, that is having the valve like structure inside it. So I'm making it over here. Suppose this is the simplest heart diagram over here. So if I say that there is foramen ovale which is present, there is a valve like structure, and how this valve is going to look like? This valve will look something like this. So if the blood comes from the right atrium, if the blood comes from the right atrium towards the left atrium, definitely the valve will open. Why? Because it is like this, you know. So what is going to happen? If from here the blood is coming, it is going to open up. But from the left atrium the blood is coming, what is going to happen? Even they are going to come closer together, right? So that means there is no backflow available. I told you that is the only difference between valve and sphincter. Both are acting as doors, but valve will allow only unidirectional flow. Thanks to this, I don't know why the lines are coming. Unidirectional flow because of presence of valve like structure, presence of valve in foramen ovale, right? So if I increase the pressure in the LA, what is going to happen? So see over here, in the left atrium I increase the pressure, and because there is no blood which is coming from the inferior vena cava, there is decrease in the right atrial pressure because maximum blood was coming from the inferior vena cava, from the umbilical vein, right? And because of this, the pressure gradient is going to change, and that's why there is closure of foramen ovale, right? Because the valve is there. And this closure is known as, so whenever there is going to be what to say, if there is LA pressure is going to increase, LAP, increase in the LAP more than RAP, so there is closure of the foramen ovale, which is known as functional closure. It is not an anatomical closure. Unless and until the fibrous tissue is formed, there is not going to be anatomical closure which is going to take place. Okay, so that is going to be the thing over here. Just give me 1 minute. Okay, so this is known as functional closure. Functional closure. All right, so that is going to be the case over here. Right, now if I say that functional closure is just because of the pressure change, the flow is reversed, and that's why it is not going to occur in the backside, right? So this is functional closure, but we have to do the anatomical closure also. So how the anatomical closure is going to take place? Once I told you there is a fibrous tissue which is going to form, and that fibrous tissue is going to make the septum. So if I have to talk about anatomical closure or morphological closure, I should talk about the growth of the fibrous tissue that is going to be there. Growth of fibrous tissue that is going to cause anatomical closure, right? Anatomic closure, anatomical closure, right? Let's move ahead. So I hope you understood that how the foramen ovale is going to change. So pulmonary arterial pressure, it is going to fall, and that's why again the right atrial pressure will fall. And what about the aortic pressure? Because of lot of back pressure on the aorta, as we medico has a lot of pressure of this population, because the number of good doctors are less, like you guys, right? And the number of the patients, they are very, very high, right? And that's why the Indian doctors overall in the world, they are known as best practitioners. Why? Because we have a lot of exposure which is not possible in the many of the countries, especially in the developed countries, because they do have less population and they manage everything well, right? So Indian doctors are best practitioner, and we should be proud that we are Indian, right? Not on the population. Now coming to this aortic pressure, it is going to increase because of back pressure, right? And that's why the whole scenario is going to take place, and this is known as reversal of pressure gradient. Okay, so reversal of pressure gradient, because of this the foramen ovale will close. We have talked about the closure of ductus venosus, foramen ovale closure. Okay, and the only thing left, it is the again the same side is there. Okay, so I'm removing, we have discussed this, so there is no need of this. Thickness of both ventricle. Now understand, ductus arteriosus we are going to discuss in a minute. Thickness of both ventricle, first of all, it should be in the fetal life, they are equal, but after birth, after let's say the development of full muscular development, it is going to be the LV muscles or LV muscle mass, right, is going to be 3 times more as compared to the RV, that is the right ventricle. Why is it so? Because the left ventricle has to push the blood, it has to apply the force, right? Lot of mental pressure on left ventricle, because it has to supply the blood towards whole of our body, from the tip of my hair to the tip of my great toe. So whole body circulation should be there from it is dependent on the force that is generated by left ventricle. So left ventricle get heavy, right? So we learn a lot, we work hard, and we get stronger every day. And who is the inspiration? The left ventricle should be the inspiration, that we have to work hard so that we get more stronger. Then coming to the right ventricle, what about the right ventricle? Right ventricle has to supply the blood only towards the lung, towards the pulmonary circulation, which is present in the thorax itself. It is not far away. And in the Bernoulli's theorem, we learn that if more is the length, the resistance will increase, and that's why there is a less resistance in the front. And what is going to happen if the less resistance is there? Definitely it is going to have less muscle mass. So who go through less resistance, what is going to happen to their life? They only know, because I don't know about that, right? Let's not talk about it. Okay, coming to the patent foramen ovale. Now understand, in some of the people, the foramen oval will not get fibrous. That means it is not going to convert into the fibrous tissue. It should be the valve which is there in the fetal life, which will be converted into 1 to 4 months. It will be converted into fibrous growth. So there will be whole septum which is going to present. But understand, in some people it is patent. Patent means remain stable, or it will not grow in as a fibrous tissue. So there is no fibrous growth even in the adult life. No fibrous growth. But will that be causing major issue? No, it won't be causing major issue, because remember, even in the diastole of the atria, the left atrial pressure always remain 2 to 4 mmHg more. This all the information I have taken from the Guyton International Edition. You can go back and read from there also if you miss any point. So 2 to 4 mmHg pressure is always higher as compared to that of right atrial pressure. Right atrial, I'll just write it downwards. Right atrial pressure. Alright. So left atrial pressure and right atrial pressure, that is going to be there. Now, let's move on to the next thing. And that's why it won't cause much of the issue. So, no nuisance will be there. Or pathology. Major disease will not be there. But this can be causing one thing, that is atrial septal defect. If suppose by any chance, if the pulmonary vascular resistance increases, such as in the pulmonary hypertension, this is going to occur. In that case, what will be there? Now the right atrial pressure start to increase. If the right atrial pressure start to increase, this valve is going to get open now. And if that opens, definitely there is going to be mixing of the blood. Okay, so if for example, in the pulmonary, so such person, if he develops pulmonary hypertension, then that is going to be major problem, because in the pulmonary hypertension, it is going to give back pressure on the right ventricle, back pressure on the right atrium also. So it is going to increase the right atrial pressure, and when it overcomes the left atrial pressure, the valve will be open. If the valve will be open, definitely I'm writing on the next page that this is going to cause, so increase in the right atrial pressure. In the case of patent foramen oval, it is going to cause the mixing of the blood, oxygenated and that is deoxygenated blood, and that will decrease the oxygenation of the tissue, because mixed blood is going towards the tissue now, not the oxygenated blood. Okay, so mixed blood will be provided towards the tissue, and that is going to cause the problem. Okay, hypoxia like condition can be developed, but the cyanosis can be developed, but it is going to develop if it is severe. Right, let's move on to the next thing. Closure of ductus arteriosus. We have seen the closure of ductus venosus. We have seen the closure of the foramen oval. Now let's come towards the ductus arteriosus. What about ductus arteriosus? Artery. First of all, I told you that the pulmonary artery has less resistance now. Why? Because understand, there is decrease in the pulmonary vascular resistance. So the resistance in the pulmonary artery decreases, and in the aorta the pressure is going to increase because of the accumulation of lot of blood, and this will cause again the reversal, and there are some effect that we are going to talk. First thing, that is functional closure is going to occur in the 1 to 8 days. The birth of the baby, as soon as it is going to take place, in some hours only this functional closure will start. Okay, I have written, so in some few hours this functional closure will begin, because there is a reversal of again the pressure gradient. Now because of this, what happens that as soon as the from the pulmonary artery the blood is not coming, the constriction of that ductus arteriosus is going to occur, because the aorta is going to have a lot of muscular tissues, right? And the arteries are also having muscular tissues which are not there in the venous. Much of the this vascular tissue is not there. So over here, what is going to happen? Functional closure because of two things. Remember, first thing is because of the muscular wall of the aorta, it will start to constrict, right? And PGE2 is important in the fetal lung, which is causing that dilatation. Okay, so who was responsible? PGE2, that is prostaglandin E2. I'm writing prostaglandin. In the adult life, it usually prostaglandins, they are known for their inflammatory effect, right? But over here, the specific type of prostaglandin that is released by the fetal tissue, that is the prostaglandin E2. Now prostaglandin E2 in the fetal life, it causes vasodilatation. I'm writing like this. On the top, N means vasodilation or vasodilatation. Now, adult life, what is going to happen to the level of PGE2? Obviously, it is going to decrease. Hai na? So, in the fetal life, it was high, so vasodilatation. But after birth, after birth, it is testing my patience now. After birth, what is going to happen? The PGE2 will decrease, and because of that, the vasoconstriction will start. Okay, so these two things are majorly important over there, and that will cause the ductus arteriosus. Again, the anatomical closure will occur, and anatomical closure will again because of the fibrous growth, and that is going to take place in 1 to 4 months. Okay, but in some cases it can be patent also, right? If the ductus arteriosus is patent, then it will be called as the patent ductus arteriosus, right? So patent ductus arteriosus, PDA is not public display of affection. Nowadays, this is somebody told me a month ago or so that they are doing PDA. PDA is not there. I was like, I don't like PDA. I was like, who likes PDA? I was thinking about patent ductus arteriosus, but he was talking about the public display of affection. I don't know this Gen Z generation, what they have in their mind. Okay, over here the PDA means patent ductus arteriosus. Now PGE2 is going to be not there. If the PGE2 is still there even after birth, if the PGE2 levels are high, if the PGE2 levels are high, this is the theory, hypothesis, or we can say that the researchers do not know the exact cause, but when they have tested the PGE2 levels in the babies of patent ductus arteriosus, they have found to be higher. So they are postulating this effect towards the high levels of PGE2. Okay, so high levels that will cause the patent ductus arteriosus to be dilated excessively. So excessive dilatation of the ductus arteriosus, and that's why it is not able to close. Now, can we do something about it? Yes, we know that it is because of the PGE2 and the levels are higher there. Give its inhibitor. Isn't it easy? Very easy. So what we can do is to treat. TT means treatment. As a treatment, if the baby's patent ductus, the ductus arteriosus is patent, that means it is not able to get close, we can give the PGE2 inhibitor. And can you guess the name? What is it? PGE2 inhibitor. and the name is endomethacin. We give this drug to the baby so that the constriction of the patent ductal arteriosus will occur. Otherwise, what is going to happen, that the oxygenated blood and deoxygenated blood will combine, and again the whole work of the lung is going to get wasted. Why? Because it is causing the oxygenation, right? You must have seen one diagram like this, a person looking like this, है ना? So patent ductus arteriosus is there, the lung will be looking like this, that I am doing all the hard work to oxygenate the deoxygenated blood, and now because of this patent ductus arteriosus, whole mixing is occurring again before that blood is reaching towards the tissue in the heart itself, in the beside the heart. This is happening, these roads are meeting to each other, and this is causing the patent ductus arteriosus. Okay, let's move on towards the PO2 level. We have discussed that before birth, what are the PO2 levels? They are very, very less, that is between 40 to 60 near the tissue, and 80%, they are around 80% at the beginning of umbilical vein. Okay, and as they go towards the tissue, the oxygen will be extracted, and as soon as the after the extraction of the oxygen, we come towards the umbilical artery. It can be near about 60 to 40%. Okay, and after the birth, it is going to be around 95 to 100%, right? Or mmHg if we talk about PaO2, right? Content is going to be in the percentage, and definitely partial pressure, then mmHg. Okay, one and the same thing, right? So this is going to happen there. So there is one more change that is going to happen after the birth. And what is this change? When the fetus is inside the mother's womb, what is going to happen? The body temperature is maintained. How? Because mother's body temperature is around 37 degrees Celsius. But as soon as delivery is going to take place, the baby is going to come out in the external environment for the first time, and he will be exposed to the room temperature. And remember, this room temperature also help to cause vasoconstriction. That means again the systemic vessels are going to have more resistance because of this vasoconstriction. Okay, and this is again the graph from the Guyton itself. You can see that as soon as the baby is born, this is the hours over here which are shown, right? In the hours itself, you can see that from the Fahrenheit, that is around 98.5 to 98.7 Fahrenheit, it is going to drop towards the 95.5 Fahrenheit. Okay, so degree Fahrenheit, that is going to be there. So you can see that the temperature is going to fall. That is also going to help, not much, but some degree, it is going to help to cause vasoconstriction. You also must have seen whenever there is a winter, you must have seen the skin is going to get dry. Why? Because the body try to conserve the heat. If you send more blood towards the skin, we are going to lose the heat, which we do not want, and that's why cold causes vasoconstriction, and that will lead to increase in the total peripheral resistance, which will help in the increment in the systemic vascular resistance also, right? And after few hours, the baby's metabolism will boost up, right? And especially they do have brown fat a lot, and that brown fat is going to giving them the heat, or they are going to generate the heat. Why? Because other mechanism such as shivering and all, that is not present in the baby. That will develop later on in the adult life, but in the babies, shivering is not present. So that's why how they maintain the body temperature, the increment in the body temperature mainly is seen because of, remember, there is something known as brown fat. We do have yellow fat. Yellow fat is a source of energy. Brown fat can be used as a source of energy, but it is mainly used for the heat generation in the babies. Heat generation in the babies. Okay, so that is the main reason over here. And what you can see later on also, it is not very stable. Why? Because the maintenance of temperature, the temperature regulation mechanisms, they are not developed in the baby. So we have to take care of the baby, that that baby will not get hypothermic. And that's why you must have heard of kangaroo method. What is it? That as soon as the baby is born, we ask the mother to hug him, right, and without any clothes. Why? Because mother has a lot of heat generating at that time because the hormonal changes. And that's why if she keep the baby very close to her body, definitely the temperature is going to increase. And if you get a chance, go to the neonatal care unit, that is, as we say, ICU, intensive care unit. We do have an ICU, neonatal intensive care unit. In that you will be sweating. Why? Because we keep the temperature a bit higher, which is good for the baby. All right. Why? Because the baby have very poor mechanism of heat generation and the temperature regulation. You can see a lot of fluctuation in the temperature, right? So what are these? Even after the days after the birth, they do have fluctuations in the temperature. Why? Because poor temperature regulation. Poor temperature regulation. All right, let's move on. In the neonate, what is the amount of blood volume? The blood volume is nearly about 300 ml. In the healthy baby, it is around 300 ml. Now there is a phenomena I was talking about, that is stripping of umbilical cord. Some of the pediatricians, they believe that if you keep the baby is born now, the delivery happened already, placenta also came out, but rather than stripping the umbilical cord right away, we give few minutes to the baby to get that extra blood. Remember, if we keep the placenta attached with the baby, keep the attachment or connection, we do not clamp the umbilical cord right away, we give some minutes, right? So keep the connection patent for some time between umbilical cord, that means the placenta basically I'm talking about, and baby. If I'm saying baby, not fetus, that means the baby is born, isn't it? So in between the baby, so what is going to happen? There is going to be extra blood which is going to go towards the baby's tissue, right? And how much extra blood the placenta can give? It is the 75 ml. So from the placenta, it is going to be the planta हो गया यहाँ पे placenta, okay? So that is going to give 75. So that means it is going to be 375 ml overall. Okay, in the normal healthy baby, this is going to be the normal value. Now some of the pediatricians, they believe that this may cause pulmonary edema. That means more blood is going to be there, which is going to accumulate in the pulmonary vessels, and since their resistance is going to decrease a lot, and that's why the blood can leak out of this blood vessel into the interstitial fluid of the lung, and that is going to cause pulmonary edema. And that can be there, but again we have to weigh the risk to benefit ratio. Over here the risk is very, very low. Why? Because the 75 ml in comparison to 300 ml is less. It may cause mild edema, pulmonary edema, but the excess of or extra RBCs that the baby is going to receive, they are going to be helpful for the baby's development or oxygen delivery, right? So that is going to be very, very important. So nowadays this practice is followed in India also. We keep the umbilical cord for some minutes, few minutes, not forever, right? For few minutes. The connection is there for few minutes. Okay, that is going to be there. All right, let's move on. Nowadays everybody is saving their blood of the baby from the umbilical cord for the stem cell, because they contain a lot of stem cells in the blood of the placenta, and that's why we store the umbilical blood so that in case later on the baby requires something, definitely it is going to charge much more. So if the baby develops some disease, we can use those stem cells as, let's say nowadays we are doing the bone marrow transplant and everything, so that is not required there. All right, so I hope you guys are alive. And somebody asked me what is the cardiac output, that is 500 ml. Now understand, almost the body weight of the baby is going to be very less as compared to the adult. We do have 5 liters, but we are at least of 50 kgs, right? So I'm telling about myself. And the 500 ml blood in the 2.5 or 3 kg baby, that is going to be much more. So if we take the ratio of the body weight per se on the cardiac output, it is going to have, the baby is going to have twice of the cardiac output as the adult when we weigh the cardiac output is to body weight ratio. So he is going to have much more cardiac output, that is going to be 2x of his body weight. Okay, what is required. Then coming to the BP, what is the BP? What do you think? The BP must be high or low? Yes guys, tell me the answers. Many more things. Somebody asked me above 95, what 95% acha hemoglobin, that PaO2 concentration. So Ritesh, you asked about it, है ना? So it is 500 ml. Can you tell me what is the BP of the baby? Chalo, tell me the BP of the baby. Anybody? So the BP of the baby, I'm telling you, or should I wait for few at least replies? Okay, let's see. So 70, that is going to be the arterial side, that is the systolic blood pressure, right? And then it is going to be 50 mmHg, which is going to be diastolic. Systolic by diastolic, this is the ideal range. Okay, but after the infancy, that means in the immediately after birth. Yes, you are right. Somewhere down the line, you are right. Rishabh, you are nearby, closest, immediately after birth. What is going to happen after few days of birth? This BP is going to increase up to what level? Up to 90 by 60 mmHg. 90 by 60 mmHg is going to be the BP after few days. In the infancy and childhood, it is going to be 90 to 60 mmHg. If you go to the pediatrics ward, their BP size, cuff size is different, and we have learned that in the last lectures in the blood pressure. So right, and if you measure that, it is going to be lower. Don't get scared, it is normal range for the baby's blood pressure, right? In the adult life, nowadays in the guidance it is mentioned 115 by 80. Okay, so that is the normal blood pressure in the, that is 115 by 80 in the adult life. Okay, coming to the ASD, what is ASD? Atrial septal defect, isn't it? Atrial septal defect, we have discussed already that in between the atria, if there is a opening which is going to be present, it might be, most commonly it is going to be the foramen well, or it might be that some mutational defect can produce the atrial septal defect. So what is going to happen, that after birth the left hand side the pressure is going to be more, so there is something known as left to right shunt which is going to take place. Okay, so from the LA it is going into the RA, and the same blood is going to circulate many times in that heart, right? Rather than going towards the tissues, it is going to stay there. So this is known as left to right shunt. I'll write it completely. Shunt means usually the abnormal connections. Rather than abnormal connection, the exact definition is that if they bypass the capillaries, okay, the connection which is abnormal in this case, but there is physiological shunt also which is going to be present in the lungs, okay. So if the root circulation bypasses capillaries, right, and that is known as the shunt, okay. If I tell you that there is one more disease that we are going to learn which is known as tetralogy of Fallot, in that the blood is going to move in the reverse direction. So next is that one only, tetralogy of Fallot. What are the tetralogy means? First of all, the tetralogy means tetra means 4. So what are the 4 things which are going to be there? Can you guess? Tetra means 4. So there are going to be 4 abnormal things which are going to be there after the birth in the baby, that is known as the tetralogy of Fallot, okay. Now what are the 4 things? First thing, remember that there will be pulmonary stenosis. Pulmonary stenosis or pulmonary arterial stenosis right, that means arterial valve, basically pulmonary valve stenosis. Now pulmonary, I'll just write pulmonary stenosis, that will be better because the valve is going to get stenosed, okay. So suppose I'm making it different atria and ventricle. So suppose this is one atria, this is another, this one ventricle, and this is another ventricle, okay. Now focus over here that I have drawn the left ventricle a bit smaller, and that is what is going to take place over here. And if I say that there is going to be opening which is going to be present in between these 2 hearts, that is ventricles. Now there are other things, that is pulmonary valve will be there and aortic valve will be there. Now there can be overriding of aorta. What do you mean by overriding of aorta? Rather than opening of aorta happening in the left atrium, it can open into right atrium itself, okay. So that means overriding of aorta, right. So 4 things are going to be there. First thing is that pulmonary stenosis is going to take place. So suppose this is the right atrium, right ventricle, and this is pulmonary valve. So if I say that there is a stenosis, what is going to take place over here? Obviously the pressure over here is going to increase, right. The pressure with which the heart has to pump the blood, there is an obstruction which is present, and that's why the pressure that the heart has to produce is going to be more. The right heart has to produce, or right ventricle has to produce, it is going to be much more. And whenever you have to act against more resistance, that means when you face more problem, what I told you, that you become stronger. So that's why what is going to happen to the muscle wall of the right ventricle? It is going to get hypertrophied, right. So the second thing that is going to take place over here is the right ventricular hypertrophy. Right ventricular hypertrophy. Then I told you there is a third thing which is going to be there, that is the septum of the ventricle. It is going to have a pore which is going to available, right. So third thing, ventricular septal defect. Right, and the fourth thing is overriding of aorta. So these are the 4 features. Might be that there are 3 features available, not the overriding of aorta, but understand this is going to be there, and this is quite possible, okay. Now understand what is going to happen. So I'm drawing the aorta over here so that you'll remember. So let's close the aorta. Rather than having the aorta opening, there are 2 openings in the, let's draw over here, 2 openings from the right ventricle and left ventricle. Now right ventricle is thicker, and that's why it is going to push the blood into the left ventricle, isn't it? So what shunt it is there? The shunt is called as right to left shunt. The blood will be forced whenever the pressure especially in the diastole, whenever the pressure is going to be higher there, this is going to change the pressure gradient, and that is going to cause the blood flow to change towards the left ventricle. Okay, and because of the back pressure, this will continue. The flow is going to get continued there, right? Let's move on to the questions, and we will get rid of this topic now. Why? Because it's already the time, right? And we are going to move on to the physiology of ECG, right? So give these shots to this questions. If these kind of question comes to your exam, what you are going to answer and what manner you are going to answer, please just jot down the points, and this is going to be very, very easy for you guys. All right, let's move on to the next thing, that is act as if what you do makes a difference. Okay, and trust me, it does, right? This is the favorite quote, my favorite quote from William James, right? So trust or have the faith that whatever you're doing, it is going to change your future, so that you'll work harder as much as it is in your control, right? With that wonderful message, let's move on to the ECG. What do you mean by ECG? It is the electrocardiogram. There are three words which are going to be definitely asked to you, especially in the Viva. What do you mean by electrocardiogram? What do you mean by electrocardiograph? And what do you mean by electrocardiography? So what these terminology meant by? Let's see one by one. The ECG is known as electrocardiogram. Now understand, when we say electrocardiogram, when the word is going to come as gram, so it is the electrical activity of heart represented in graphical manner. Or you can say recording of electrical activity of the heart, which is represented in a graphical manner. We are just recording it, and that recording will be called as gram. Okay, so please remember, whenever the word says gram, means the recording of the electrical activity of the heart. Okay, next, coming to the electrocardiograph. If you understand electrocardiograph and graphy is easy. Whenever Y is going to come, graphy, right, or metry, like that, that means you are doing the procedure, right? Procedure of recording is going to be called as graphy. So whatever procedure we are going to follow for the recording, whenever method or procedure is there, that will be called as graphimetry. E is going to come in the end. So please remember, whenever they talk about method or procedure, it is going to be graphy which is going to come. Then third thing, that is graph. What do you mean by graph? The machine with which the recording is done, that is known as electrocardiograph. So there are three different terminology. It means three different things, right? Don't get confused. It is much more easier if you understand it completely. Understand, the machine is the graph. You do have graph inside the machine, so you can remember like that. A gram means recording. Okay, though people usually, the students usually get confused between graph and gram, but gram means simply the recording of the ECG, and graph, the graph paper is there, which is there inside the machine. So that's how we used to remember. Graph means machine. Okay, M never goes with M. Gram is not the machine. Okay, graph is the machine and gram is the recording. Okay, let's move on. Now, what is the principle on which it is based? Remember, the Anthovan was the scientist which is who discovered this. I'm just writing. Okay, so what is the principle on which it is based? So remember, there was a scientist which is known as Einthoven. Einthoven was the scientist who discovered lead and he tried the ECG for the first time. Then at that time he used NaCl as the jelly or the conductor. Later on he got to know that we do have the blood which acts as the good volume conductor. So that's why we don't have to pierce the skin and the soft tissue and reach up to the heart. Why? Because we do have electrolytes in our blood and electrolytes in our tissues. So what is going to happen? The body is a good conductor of electricity. There are minute amounts of currents which are generally present, that is depolarization, repolarization, right? And because of that, what is going to happen is that those changes will come onto the surface. They are very, very minute, so we won't be able to recognize them in the daily life, but they are there. So what we need to do is, it is a good conductor, so that's why we are going to attach electrodes and attach voltmeter and check the potential difference. But that potential difference is not enough so as to get the waves, proper waves, and differentiate between one ECG and another ECG. So that's why we have to amplify it. So after doing these adequate amplification, we are going to get the proper graphs, right? Now you have to tell me what is the difference between ECG and action potential. The cardiac output bache, each ventricle we talk about that, right? So cardiac output, if we take off the left ventricle, definitely it is going to decrease. Okay. Yes, Vaishnavi. Very good. You were not there in the last class, right? I didn't see your comments. Alright. So can you tell me what is the difference between ECG and the action potential? We have learned the action potential in the heart and we are learning the ECG. Is there any difference in the waves, in the electrolytes? What do you think is the difference? Remember, the action potential, when we measure it, it is denoting the electrical activity in single muscle fiber. When we summate all those fibers action potential, we are going to get an average electrical activity in a combined manner, which is going to give a wave to us, and that is nothing but the ECG. When we do the summation of action potential of all atrial or ventricular muscle fibers, atrial, I'll just write or ventricular muscle fibers, it is going to show us the what thing, or it is going to give us the ECG. That will be called as ECG. So this is the summation of atrial or ventricular muscle fiber. So this is the summation of, so that is nothing but the ECG. That is the only difference between these two. Alright, let's move on. What is the physiological basis or principle on which it works? It is the dipole. What was the dipole? So see over here that there we require two different poles of two opposite charges. That is, one is going to be positive pole, another is going to be negative pole. But the magnitude of current in them should be similar. whenever the positive electrode is there, negative charges are going to move towards the positivity, and the positive charges, they are going to move towards the negativity, which is going to take place, right? So see over here, the ECG records the voltage between the dipoles produced by electrical activities of the heart, right? And whenever the electrical activity changes, the positive and negative charges, they are going to move towards each other, right? So two poles are going to get generated because of this, and those two poles do not remain stable. They will keep on moving as the depolarization is happening towards the next area, right? So the ECG records the voltage between the two things, that is the dipole produced by the electrical activity. So the dipole is produced by the electrical activity, and though two poles have opposite charges, they have current which is equal, that is magnitude which is going to be equal. Combination of these two poles which has equal and opposite charge, that is known as the dipole, right? So this is the simple funda, that the negative charge particles, they will be moving towards the opposite charge, that is towards positivity, right? And the positively charged substances, they will be moving towards the negativity. So over here what it is showing, the battery is there and the magnitude, suppose 10 millivolt current is there, 10 millivolt will be there in this also, right? So same magnitude but opposite charges. Same magnitude but opposite charges. So you can see, for example, if the dipole is there in the atria, it is going to give different wave. If there is a depolarization occurring in the next area, I told you it is going to start in the middle of the septum, ventricular septum, and then it is going to move ahead like this, okay? So there is a bundle of His which is going to get activated, and then via the gap junction the septum is going to move like that, and we have discussed that very well in the cardiac cycle also. And that's why if they ask what is the third last part to be depolarized, it is going to be the upper part or the basal part of the interventricular septum that we have discussed, okay? Then the whole ventricle is start to depolarize, and you can see over here the septum is still not depolarized completely, but last three parts, this is taken from the Genong itself, that the last three parts to get depolarized are the basal area of the ventricle, right? That is the basal area of interventricular septum, then the pulmonary conus, and then the posterior basal part of the left ventricle. Okay, we have discussed that already, okay? And that is going to give the whole QRS complex completion, and then the T wave will be coming. That means it is showing the repolarization, okay? Now, how the dipole is created, we have already discussed that there are two poles, one negative and one positive, and because of the depolarization, that is nothing but the excitation. So depolarization creates the dipole. The region of myocardium which is already depolarized, it will be negative pole, and the region ahead of that, that is going to be positive pole, okay? So remember only these two things over here, whichever already depolarized, that is going to be negative pole, and which is about to get depolarized, that will be positive pole. Negative and positive pole, the poles shift from one region to another region, and that's how the next and next dipole will be giving us different waves and different depolarizing areas, right? Coming to the ECG leads, that was the principle behind the ECG, how we can record it. Now coming to the ECG leads, what are the standard leads? There are let's say 3 lead ECG also, 6 leads ECG, 9 lead ECG, 12 lead ECG, 15 and even 19 lead ECG is there, but we do not require that much of the leads of the ECG. What do you mean by ECG and why we require so many lead? Understand, suppose I have a big scar over here, right? But I want a good picture. What I'm going to do, I'm going to pose like this, right? But if someone want to see me completely, that is not going to give a proper view. So I have to take a picture from this side also, right? So that's why to get a picture of the heart from all the side, we have to take the picture from all the side. What is the difference between ECG and echo? When we discuss the cardiac output, we have talked about the echo. Echo is the ultrasound of the heart, right? In that, it is like a video which is played. Okay, so if we see, we can see blood coming, going out, right? Valve method, the heart contracting. We can guess because the shadow is going to change in the ultrasound or echo. So echo is like a video which is going to be better, but ECG can give us the per se the idea about which area is healthy, which area is getting infarcted or hypoxic, ischemic, like that, right? So what are the standard leads, or what are the number of standard leads? It is the 12 lead ECG is going to be standard one, isn't it? Now understand, there are two types of lead. Okay, I can divide it in different types, but I'm going to do what is most accepted in the physiology. That is whether it is bipolar or unipolar. Remember, bipolar means 2 electrodes are required. If I have to measure the potential difference, 2 electrodes are must. 2 electrode is going to form the lead. Then only I will be able to measure the difference between two. But there are unipolar leads also. So let's see. I'm going to divide them into two parts. What are the two parts? First is the bipolar lead, which are known as the Anthovan's lead again, right? Or known as limb leads. Okay, so bipolar, that means they are going to have 2 electrodes. They are going to have 2 electrodes. And what do you mean by unipolar? That means they don't have 2 leads, or they don't have 2 electrodes, they have single electrode. If they're having single electrode, how they're measuring the difference? That is your question. Yes guys, in the comments answer me. If there are no 2 poles to measure difference, I have to have 2 different electrodes, right? But over here only 1 pole is there. That means only 1 single electrode is there, and still we are able to measure the potential difference. How? That is your question that you have to answer, right? So what are the Anthovan's lead? That is lead 1, lead 2 and lead 3. Thankfully there are no weird names to it, right? Okay, so lead 1, lead 2 and lead 3, which is going to be there. Okay, now there are going to be leads which are unipolar also. How many leads are there which are bipolar? There are 3 leads. Out of 12, if bipolars are only 3, remaining 9 are going to be unipolar. How difficult that is? Very difficult, है ना? That's why we left the maths and took the MBBS. But anyways, it's very easy to remember. 3 are limb leads, Anthovan leads, and then we have 9 unipolar leads. Again, I'm going to divide them into 2. First thing, there are augmented leads, which are also known as Goldberger leads. Why? Because it is discovered by the Goldberger scientist. And there are going to be chest leads, Wilson leads. I'm going to show another chart also. Everything is written in that. You can take a screenshot of it. Now, augmented lead, again there are 3 leads. So how many are left? So 3 leads are there in the augmented. 3 leads were already done in the limb leads. So remaining 6 are going to be the chest leads. Okay, so that is going to be the distribution. Now what are the augmented lead? I'm just writing over here the triangle, or drawing over here the triangle in which we do have what thing? So let's draw the triangle itself here itself. It will be helpful for you to see. Alright, so suppose this is the triangle. Now this triangle, it is seen that, or it is assumed or postulated that the heart is in the center of this triangle, and this triangle is made by the electrodes itself. And what are the sites on which we are going to place the electrode? Right arm, left arm, and left leg. In the books it is written as left foot also, but I'm writing left leg. You'll understand why, because there is a mnemonic slight trick in this to remember. Now, how to remember which one is lead 1, which one is lead 2, and which one is lead 3? There is a simple way to remember. The number of L's you have to calculate in this RA, LA, and LL. Wherever the numbers of L is going to be matching, that is going to be the number of lead, and that is also going to be the positive electrode. Okay, what I mean by that you'll understand just now. See over here, if I take the lead over here from RA to LA, if I take the lead that is from RA to LA, how many L's are there? There is no L in the RA, and there is only one L is there in the LA. So this is going to be lead 1. So this is going to be the lead 1, isn't it? Now see over here, there are another leads also. So if I take from the RA to LL, so there are 2 L's in the LL itself, right? So that's why I'm going to write it as lead 2. And if I calculate from here to here, how many L's are there? 1, 2, and 3 L's are there. So I'm going to write over here the lead 3. Okay, so it's very simple. You have to just calculate the number of L from where to where it is coming. In between LA and LL, there are 3 L's. So that's why I'm going to write it as lead number 3. Same over here, we are going to do augmentation in some leads, that we are capturing the electrical signals, but we are amplifying them. Okay, so what they are called as? They are called as AVR, AVL, and AVR, that is towards the right arm, right? The AVL, that is the left arm, and the AVF, this is for the foot. That means the left leg that we are talking about. Okay, we don't have to differently attach any leads. The machine itself is going to do the augmentation. They can ask you how many times the augmentation is there. Augmentation means amplification, right? So this A denotes the amplification, V denotes the voltage coming from which side, whether it is from right arm, or left leg, or left foot, right? Depending on that, we are going to write the augmentation. Now, how many time amplified waves we are going to get, or the electrical activity? Remember, it is going to be the 1.5 times. The augmentation or amplification is going to be 1.5 times or 3/2 times. Okay, 1.5 times augmentation is going to be there. Okay. Now coming to the chest leads, there are 6 chest leads. I'll tell you the site to attach also. So for now, just write V1, V2, V3, V4, V5, V6. Right? Why we require so many leads? Because we have to take the pictures from all the sites, from 12 different sites, so that we do not miss if there is any MI, that is myocardial infarction is there, or angina which is taking place. And that's why we have to take the pictures from all the sites. Okay, otherwise we can miss the patient of myocardial infarction also. That is the major change, right? I told you that there is another division which can be done like this, that is 6 limb leads and 6 chest leads are going to be there. Again, limb leads are going to be the unipolar leads or bipolar leads, that is the augmented leads. These are nothing but the augmented leads, which are unipolar leads, and then the bipolar leads. Again, the 6 chest leads are going to be unipolar leads. Right, so information looks over here very incomplete, and that's why I prefer to write that chart which we have made on our own, right? So this is given in one of the Indian author books, so that's why I don't prefer that, right? unipolar and bipolar, but you can write that as well. Okay, so AVR, AVL, AVF, I told you that augmented lead are called as Goldberger leads. How to remember? There are two G's in this. Okay, that is the Goldberger and augmented lead. Okay, that's how you can correlate with it and you can remember what it is called as. Okay, standard limb leads, from where the whole process of ECG started, and we should be very, very thankful to this Anthoven who did the work for us. And Anthoven is the one who gave this triangle, and that's why this triangle is also known as Anthoven's triangle. Anthoven's triangle. Okay, so I'll just write there. So this is also known as Anthoven's triangle, ET. I'm just writing Anthoven's triangle over here. All right, so he gave the limb leads. He started his research via the limb leads. And if you have only one lead to take, which lead you are going to take? You're going to take lead 2, because see the direction of the lead 2. It is in the same direction in which the depolarization of the heart is going to occur. It is from the right side towards the left side, right? And from above downward, from the right atrium, the pacemaker will start the action potential and it will carry forward the depolarization towards the left ventricle, right? In that direction, the depolarization is going to take place, and that's why lead 2 is the most important lead, which will give the maximum information about the heart. Or if I have to take one lead, I'm going to make the long strip of lead 2. Okay, now the V1, V2, V3, V4, V5, V6, they are known as precordial leads of Wilson. I told you Wilson was the scientist who developed this chest leads. Okay, so chest leads, Wilson. Now coming to the leads, if you do not know which lead to attach where, because remember they do have proper connections, proper color coding, you cannot just attach any lead anywhere, because accordingly your graphical representation is going to change, which can change the conclusion or which can change the result. So you cannot just attach any lead anywhere. Red color lead in the foot, no, that is not there. There is a proper color coding, and I'll tell you how to remember that. Now remember, the red starts from R, so it is going to go in the right arm. Okay, right foot we haven't discussed about it. Why? Because the right foot, it is having the black color lead, and the black color is used for what? For the earthing, right? So red color, remember, in the triangle, that is denoted by the RA, that is right arm. Then exactly in contrast, we go in the wavelength, it is very, very high, the red color, and the yellow is less. So in contrast, usually we talk about yellow color. So yellow we are going to attach on the left arm. Foot, in the foot we are going to attach green for ground, or on the ground we put a foot, right? So you can remember that ways. Otherwise, if you can remember easily, you can remember also. So green is for the foot or ground, right, on which we do have legs. So you can remember the green is on left foot and the black is on, there are 4 leads which are here, but it is not going to give any wave. It is for the earthing or grounding effect. Okay, so that is there, right? So there is one law also there, which is known as obviously Anthoven's law. We saw the Anthoven's triangle, now the Anthoven's law. This is the Anthoven's leads. Anthoven's leads, right? Anthoven's law, it is saying that if you combine the lead 1 and lead 3 potential, you're going to get the lead 2. That is, the lead 1 plus lead 3 is equal to the potential of lead 2. Right? And if you know any 2 leads for that matter, you can calculate the third one, and that's why it is very, very important to know the Anthoven's law, right? Lead 1 plus lead 3 minus lead 2 is going to be 0. Okay, so this is known as, it is already written over here, that is Anthoven's law, right? And in the Anthoven's triangle, one thing I was telling you, that wherever the L is more, for example, in the right atrium and left atrium, only one L is there, right? So that becomes positive pole in the lead 1. In the case of lead 2, see over here, there are 2 L's. So in this lead, this becomes positive, isn't it? And in the lead 3, again the LL is going to have 2 L's. So that will win. So in this case also, this becomes positive lead. Okay. So that is going to be there. And if you take the 360-degree angle, because we are attaching the 12 leads in that ways, and we are taking or covering the 360 degrees, if you take so, then the 0 degree will be the lead 1, 0 degree will be taken as lead 1, and somewhere here it will be 90 degree. More than 90 degree is around 110 to 120, we do have lead 3, and around 60 degree we do have lead 2, right? And I'll not discuss the cardiac axis because we don't have time. It's already almost 8:30, right? So we will discuss the cardiac axis in the whenever the first Prof main recordings will be out, right? Or if you want to know about cardiac axis, I have discussed that on my channel itself. You can go there and you can watch it by free thing, right? It's not charged. Now if I talk about this cardiac axis, just remember what is the normal cardiac axis. That means cardiac axis means what is the direction of depolarization that I'm talking about, okay? So what is the normal cardiac axis? It is going to be minus 30 to plus 110 degrees. Minus 30 degree to plus 110 degree. That is going to be the normal cardiac axis. And lead 2, we usually generally calculate the lead 1 and 3, and we draw a perpendicular line from them, and wherever they intersects, from there we are going to extrapolate that line towards the center, and we are going to measure from the 0 degree, that means from the 0, that is lead 1, and we are going to measure the axis via D also there, right? These are the leads. That's how they look like. 12 lead ECG. Remember I told you there are 3 limb leads, but we do have black also for earthing, right? So I told you red is going to go in the right arm, yellow in the left arm, then green in the left leg, and black in the right leg. That is for the earthing. And I told you there are 6 chest leads which are going to be there. And what are the chest leads? Over here you can see this is V1, V2, V3, V4, V5, V6. Where we are going to attach them, we'll see that also. We just have to know 2 intercostal space, 4th and 5th. Okay, from right side we are going to go towards the left side. That means V1 will be attached on the right side. On the other hand, on the left corner it will be the V6. Okay, and we don't have to attach any leads per se to calculate the augmented or get the augmented waves in the augmented leads. Why? Because they will be calculated with the help of limb leads itself. So these are the limb leads and these are the chest leads. We do not attach any lead specifically for the augmented one. This will be calculated by the limb leads itself, right? We do have some questions also in the end. Especially I put the MCQs because otherwise it will be boring, right? But you have to answer for that, right? Next, coming to the 1, 2, 3, 4, 5, what can you see over here? That we have to come on to the 4th intercostal space, parasternal lines. First of all, understand what do you mean by parasternal line. There is a sternum. In the middle of sternum, it is going to be sternal line. Okay, so in the middle of sternum, if I see, that is going to be sternal line. And if I check the sternal borders, it is going to be parasternal line, just in the periphery of the sternal. So over here, I'm going to attach V1 and V2 in the parasternal line. In which intercostal space? 4th intercostal space. Which side? From the right we are going towards the left, so V1 will be attached on the right side, V2 will be attached on the left side. Whenever you are going to tell the site of these leads, what you have to do? Yes, we do have blank page. So whenever you are telling the site of the lead, please tell 3 things. First First you have to tell about the side, on which side you have attached it. Second, you have to mention the line, that means which line, parasternal line, then there is a mid-clavicular line. After that there is anterior axillary, mid-axillary, posterior axillary, where the axillary fossa has ended over here. We are going to draw imaginary line, and this line will be called as posterior axillary. Then comes the scapular line, paravertebral and vertebral. Like that we have completed the circle. So these line you have to tell on which line. And the third thing is intercostal space. Intercostal space, ICS means intercostal space. If you say these three things, there is no chance that you'll miss this. Okay, so please tell all three things whenever you are telling the site. So I'm going to write the site of these chest lead V1 to V6. So remember over here, V1, I told you, for V1 and V2, we have to remember the fourth intercostal space. What is the side? Only one lead will be on the right side, parasternal line, and fourth intercostal space. So I'm writing in the reverse order. We are going to attach the V1 on the fourth intercostal space on the parasternal line on the right side. Right side of the body. Okay, and what about the V2? V2 will be attached on the fourth intercostal space. I'll just do same thing like this. So fourth intercostal space, parasternal line. What is the difference? Rather than right side, we are just attaching on the left side over here, right? So this is going to be attached on the left side. That's the difference, right? What about the V3? Just give some pause. We'll go jump onto the V4 and then we'll come back to V3. Okay, just see first where the V4 will be attached. V4 will be attached. Now we have to change the intercostal space. V4 will be attached on the fifth intercostal space. Even V5 will be attached on the fifth. V6 will be attached on the fifth intercostal space, and they will be attached on the left side. Everything will be attached on the left side from here onwards, because I told you we are going to go from the right to left. Okay, so same side. So only one thing which is on the right side, that is going to be V1. All other leads, they will be attached, or electrodes, they will be attached on the left hand side. Okay, now understand that where V4 will be attached, will be attached on which line. That is important. That is mid clavicular line. I'm writing over here, that is mid clavicular line. Okay, fifth intercostal space, mid clavicular line on the left side, that is going to be your V4. And coming back to the V3, we don't have particular space or particular line. The center point of this V2 and V4 is going where we are going to attach the approximately central, we are going to attach the V3. That means V3 is attached between V2 and V4. V2 and V4. Even if it is coming not on the intercostal space, on the rib also, you can attach it there. Okay, so V2 and V4, in between that, whatever point we get, we are going to attach the V3. The distance should be same from both the sides, right? I started having slurred speech. Anyways, so let's move on to the next thing, that is we have discussed fifth intercostal space, fifth intercostal space, fifth intercostal space for V4, V5, V6. V5 we are going to change the line from mid clavicular line. We are going to come now to the next line, that is the anterior axillary line. Then on the V6 we are going to attach it on the mid axillary line. Okay, so mid axillary line. So only one thing that you have to remember, that you have to mention all three things whenever you are telling about the site of the lead where we should attach it. Okay, so same, it is shown over here. You can see this. It is not a 3D diagram, but you can see that V1 is attached on the parasternal line, fourth intercostal space. Then again this will be attached fourth intercostal space on the right side. Then V4 will be attached on the mid of the clavicle, and that's why they have shown that approximately we are going to take the mid side. So over here we have the mid clavicular line. So we can see over here that this is the mid clavicular line on which we attach on the fifth intercostal space, we attach the V4, and in between the V2 and V4 we have attached the V3. V5 on the same intercostal space, but remember the ribs, they go obliquely backwards. Okay, so slightly it will be downwards, right? In the diagram it is going up, but it will go a little bit downward, and wherever the fifth intercostal space will be carried, on the anterior axillary line and on the posterior axillary line will be having V6. Okay, the posterior axillary line is not possible, so they have shown it anteriorly itself. Okay, so that is the thing. You can see over here fourth intercostal space and fifth intercostal space. Fourth intercostal space we are going to attach two leads, that is V1 and V2. V3 in between V2 and V4. All other leads, that is V5, V6, V7, V5, V4, V5, V6, that is going to attach on the fifth intercostal space. Okay, and the sternal angle or angle of Lewis we are going to take. From the angle of Lewis we are going to go laterally, that will be counted as second rib. Okay, so you can see this is the angle of Lewis over here. So this is the angle of Lewis over here, and you can see it is, when you go laterally both the side, it will be attached to the second intercostal space. Below the second rib, below the second rib it will be second intercostal space, then the third rib, third intercostal space, fourth rib, fourth intercostal space, so on and so forth, right? If you are not getting idea, just remember below the area of the nipple or below the area of the areola of the breast, there will be fifth intercostal space which is going to be present, right? Coming to the paper, good evening Rahul, very good evening, right? And coming to this paper ECG, you will see it is going to have paper like this. So you can see two things over here. First thing is there is a box, right? There will be small box inside those large boxes, right? Large boxes are going to be there and smaller boxes are going to be there. Large boxes and smaller boxes are going to be there. Just 1 second. Alright, so large boxes and smaller boxes are going to be there. Large box, each large box will be having 5 by 5 column. That means they are going to have 1, 2, 3, 4, 5 smaller boxes, row and columns both, right? Now this box will be called as bigger box, which I have mentioned in the paper also, and inside it there is a smaller box which is going to be present. So this is known as one smaller box. So suppose this is the one small box. Okay, the larger box, it is going to consist of different things. First of all, let's see what is there on the x-axis and what is there on the y-axis. So please remember that x-axis will denote the time or the duration and y-axis will denote the voltage or the potential difference, and that is nothing but the voltage. I'll write voltage over here. Now how much is the small box? It is of usually 1 mm, right? It's very teeny tiny, and that means the whole thing is counted as 5 mm. And remember, the 1 mm, it is denoting 0.04 seconds. Okay, so if I take the x-axis of 1 mm, that is going to take 0.01 second. And if I talk about the 10 mm in the y-axis, it will be denoting the 1 millivolt. 1 millivolt, you can convert that to 1 mm, it will be 0.1 millivolt. Okay, so that is going to be there, right? And if I pick up, there are speeds like 25, 50, 75 like that mm per second, but standard speed is going to be 25 mm per second. What do you mean by standard? If specifically it is not written on the paper what is the speed, it is understood, it is the unwritten rule that the machine has been running the paper on this speed, that is the 25 mm per second. That is the normal timing, isn't it? And this is the speed that we have to calculate the heart rate with it. Okay, and for all the wave duration, all the other things, the speed is going to be very, very important. And when we have to calculate the potential difference, then the voltage is going to be important. So x-axis, y-axis, time, voltage. One small box is going to be of 1 mm, which will be equal to 0.04 seconds, and this will be 0.1 MV, that is millivolt, right? Let's move on forward. What is the physiology of ECG? The net direction of the wave changes continuously during each cycle, right? And the changes in the deflection, that is going to show the ECG. For example, the depolarization is going towards one electrode, but if the electrode is attached on the backward, that means let's say if I'm talking about depolarization and there are two electrodes which are attached, it is going towards one electrode and it is going away from one electrode. So accordingly, both the electrodes are going to show different changes. Towards where it is coming, it will be showing positive deflection. So that what it is saying, that the direction will decide what is the deflection that is going to come in that particular lead. Okay, and the size of deflection depends on the depolarization, how much depolarization is there, and how much depolarization, that means how much muscle mass is present and how many muscle fibers are producing the depolarization. According to that, the voltage is going to change, and if you change the voltage, the size of deflection is going to change, right? Suppose this is the baseline and we do have more muscle mass, so it is going to show more deflection, right? So the wave which is produced away from the baseline, that is known as deflection. Okay, so this is the baseline. How upwards or how much downwards it is going, that is the deflection. Okay, and if I say about the direction of the wave, that is dependent on the direction of depolarization or repolarization. What I mean by that, I'll tell you that. Okay, so if I have less muscle mass, there will be more muscle mass and less muscle mass. That is going to show less deflection, isn't it? So that is going to be the case in this scenario. Now, what I was talking about, depolarization and repolarization, that depends on spread of this wave towards positive electrode or negative electrode. We are going to make a simple chart out of it and then we'll see how it is going towards or away. Now remember, if it is the wave of depolarization and or if the wave is of repolarization, it is going towards the electrode and going away from the electrode. Okay, now for now just understand it, the towards and away from the electrode, whether it is negative or positive. Why? Because that is the dipole and the magnitude is going to same, it's just that the charges are different. Okay, if it is a wave of depolarization, that means positive charges are moving, right? If they are coming towards that electrode, suppose I have attached the electrode over here, right? So SA node, as it is going to fire, it is going to go away from that electrode, not towards. But if I see the V1, that is going to be showing V1, that is going to be showing that the depolarization wave is coming towards it, right? The depolarization wave or depolarization action potential, it is coming, the depolarizing wave means one and another different depolarization is moving in the different segment. Okay, so if that is happening and the depolarization wave coming towards the electrode, it is going to show positive deflection, and it is going away from the electrode, it is going to show negative deflection. Okay, and vice versa, if the repolarization is there and the wave is moving towards the electrode, it will show negative deflection, and if it is going away from the electrode, repolarizing wave, it is going to show positive deflection. It is understood that I'm talking about deflections. Okay, so please remember this. Accordingly, the waves are going to get different in the different leads. Okay, and I have this GIF, but this is PDF, so it is not working. What I wanted to show you over here is that atria will be depolarized first, especially the right atrium where the SA node is present. From here it is going to go towards the left atrium. I have this, let's see, alright, I have this GIF. You can see that how it is moving and how the waves are coming. Okay, so for example, if I say that it is going to move first of all in the atria, what you can see over here, that the P wave is forming, right? So okay, if I start only, then only I am going to able to write over here. So P wave is going to start. So here I'm going to have what thing? I'm going to have the ECG wave which are shown below, right? So that is the case. So if I say that from here, you can see that in the middle region it will start first, right? Over here it is going to start, and when the ventricle are depolarized, you can see that there is QRS wave, P wave, and then the QRS will start. In the septal depolarization you can see S, and then we have QRS complex which is going to give the when the ventricles are depolarized, and as soon as the repolarization is going to be there, it is going to cause the, that means diastole is going to be followed by it, and T wave is going to be there. So that's how it is going to be happening in the case of the ECG, right? And the one thing you have to remember, that the bundle of His starts in the middle of the septum, interventricular septum, and that's why these three parts are going to be depolarized in the end. Okay, so that is the scenario in this case. Let's move on to the next thing. You can see over here that every one of us knows that P wave is because of atrial depolarization, QRS is because of ventricular depolarization, and the T wave is because of ventricular repolarization. Where the atrial repolarization is gone, remember we have done such settings that we want only the largest amplitude or largest potential difference to be graphically represented. Why? Otherwise there will be many deflections which are going to be there, which are the artifacts. Artifacts means they are the machine's error. Okay, so we do not want any artifact, we want a clear graphical representation. That's why inbuilt in the machine we do have such arrangement that it is going to measure only the largest potential difference wave. Okay, and that's why if we talk about, if we see the muscle mass of the atria, and if we see the muscle mass of the ventricle, obviously the ventricular muscle mass is much more, and that's why when the atria are getting repolarized, at that time the ventricles are getting depolarized, and that's why it is hidden behind the QRS. That means we cannot see that. Why? Because the machine couldn't pick it up, or it will just filter it out. Okay, sometimes we can see U wave, it can be normal. And why there is U wave present? Because the papillary muscles are there in the ventricles which hold on the papillary muscles which hold on to the chordae tendineae, and this chordae tendineae helps to place the valves in the correct position so that it won't open in the another direction. And please remember, I have seen such cases that if the chordae tendineae ruptures because of any accident or the major trauma, if they rupture, definitely there is going to be regurgitation which is going to take place. All right, so everything is written already. Now let's discuss about the intervals and segment. What are the differences between interval and segment? What you can see, this is the PR interval. For example, let's take this PR interval, and this is the PR segment, or let's say ST segment over here, and you can see that there is no ST interval per se. So PR interval I have shown, and the PR segment I have shown over here. What do you think is the difference in them? So I'll just highlight this point over here. So this is the PR segment. In the segment, it's just the straight line which is going to come. S for segment, S for straight line. That means no wave included. Right? So segments are going to be only just lines, right? The basal lines or the baseline which are going to included in the segment. So you can see over here ST segment, TP segment also, right? So the segments won't contain any wave. So you cannot see any wave. They are the baseline which are shown. On the other hand, see in the interval, what is happening? If I talk about the PR interval, see over here, it is from the beginning of the P wave and at the beginning of QRS complex. And see over here that we have included the P wave over here. So there is a deflection which is included. So if the wave is included, that means it is interval. Wave is included, it means it is interval. Don't forget that. Okay, it's the easiest way I can tell you, right, how to remember it. That is the difference. Included. Okay, if the waves are included, that means it is interval. If the waves are not included, that means it is segment. So we do have different intervals. So they are given over here already. You can just see and see that from where to where. The PR interval, beginning of the P wave till the end of AV delay, that is nothing but the starting of QRS complex. RR interval, from the one peak of R wave till the next R wave peak. That means the next cycle will be starting. The QRS will be like that. P QRSG, like that. The ECG strip will be there. So R to R, the consecutive next R, peak of the R from the previous one is RR interval. So T and P are going to come inside it. Okay, what is the J point? J point is where the S wave ends and the baseline comes. Okay, the S wave comes to the baseline, that exact point where the T wave is about to start and the S point has ended, and that is the point J point. What is the significance? Whenever there is going to be infarction, this is going to get elevated. Okay, and that is known as the ST segment elevation MI. Okay, QT interval important hai. That is going to be starting, as the name suggests, beginning of the Q, end of the T, QT interval. There are two segments just shown over here, ST segment and TP segment. We have discussed the PR also. So you can see, depending on the spread of whether depolarization, repolarization, these all waves are normal. It's just that different segments are going to show them differently. Why? Because see, all the waves are negative in the AVR and they are positive in the lead 2, because lead 2 is exactly opposite in direction that of the AVR, and all the waves or depolarization is going to go away from the direction, is going to go away from the AVR, and that's why all the waves are negative in the AVR. Okay, so all the waves are normal. So this is the Genongska diagram, and you can see the waves are given over here. They are going to be normal. Last 5 minutes, let's discuss quickly abnormal cardiac axis, which is -10, +20, +90 or 120. I told you it is from -30 degree to +110 degree. So the answer over here is +120 degree. If the cardiac axis is there, it is going to be abnormal. Which one of the following lead is bipolar? Thankfully, it is bipolar leads which are simplest to remember. That is 1, 2, 3, है ना? Which we have learned in the LKG, UKG. So lead 2, right? And this is the most standard lead. Anther lead 2 is directed from. So always we are going to take negative pole first and then we are going to go towards the positive. And we know that lead 2 is going to follow the direction of the depolarization, that means from RA to LL in the Anther triangle. So the answer over here is option D, that is from right arm to left leg. And I have told you to remember the number of L's we have to count. You can see in this we have number 2 L's and in this only, right? So this will be out already, right? From LL it won't go up, or at least the third one, and we have to know that from negative to positive we are going. So LL should come afterwards. Why LL cannot come first? Because they do have 2 L's, which is not there in other things. So it is going to be the maximum L alphabet or words. So that is going to be the positive pole in all the cases. One small square of ECG papers represent how much duration? 0.04. So they won't be giving you direct question, just modify the question, right? And they will give you another questions, but if you know the concept, you can solve that too. As you are going to move forward, we will be discussing difficult questions, difficult MCQ. If you want, please let me know in the comments. Okay, don't wish for it. There is no other way. You have to work hard for it. Okay, even to make this PPT, even to do everything, we have to work hard. Okay, so just don't sit there and wait for magic to happen. The magic in your brain, that means you have to make more synapses with more revisions and more reading. Okay, so work for it. That is all from my side, and I will take your leave with this wonderful message, guys. Let this light of enlightenment sprinkle on you, and please be enthusiastic whenever you are learning something new. Just don't let the fear get in you, right? And that is what I wanted to say over here, right? I hope you enjoy the session, and we'll see you soon next week. Until that time, just revise and keep calm and maintain your perfusion, right? See you. Bye bye. Good night.